I'd like to discuss today the editorial that I've just written in the International Journal of Clinical Practice relating to the article written by Harold Bays and colleagues about the bile acid sequestrant acceptability scale and how this actually relates to the assessment of side effects for some drugs which are unconventional in their side effect profiles, and what this actually may mean in terms of how you validate new compounds. One of the problems that we always face in drug development is not improving efficacy. There are very well established methods of doing that, but in actually quantifying and identifying side effects, particularly vague ones, because how do you compare compounds that just make you feel a little bit unwell in a non-specific manner? And as drug development has gone on, efficacy measures have become more and more sophisticated, but the problem has been that there has been relatively little less effort put into the development of side effect scale scores. Increasingly, as we have an elderly population and we have a population that actually will not accept the drugs in terms of side effects that their parents' generation took 20 odd years ago, we actually have to look at really focusing on side effects. Now, the importance of this paper is that it takes a long-standing drug class, the bile acid sequestrants, which have been in use for about 30 years and have got a proven evidence base in reducing cardiovascular events in the lipid research clinics trial. What Harold Bays and colleagues do is that they actually come up with an acceptability score. The previous scores have always used the wine testing test. So how gritty does something taste? How unpleasant is it? But these are for whether your Chardonnay is a little bit off, not whether you're actually going to be able to take something on a long-term basis. Now, the bile acid acceptability score actually looks at things like mouthfeel, it looks at acceptability, it looks at all the short-term side effects that might actually mean that a patient takes one look at this drug and says, yuck, and decides that they're never going to take it again. Because typically, people will give something only one or two goes before they decide that they're never going to take the drug again. So that's the importance of this. And we have used agents to reduce bile acid metabolism for years. We've gone from the days of cholestyramine and cholestid, which actually cause side effects in about 40% of people, to newer agents like colesevelam, which cause gastrointestinal effects in 10%. And the BASA scale here is used in a trial of colesevelam to show that it is actually reasonably acceptable in terms of a small-scale trial. What it doesn't do and what it cannot do is look at long-term side effects. And in terms of long-term side effects, there are scores, but we actually have to look in different areas. And one of the things that you can look at, which has virtually a parallel profile, but looking at chronic side effects, is the use of something from the irritable bowel syndrome, or the IBS-SSS score, which actually looks at does something cause bloating, does it cause nausea, does it cause diarrhea and constipation. And that may be that to actually assess the side effects of bile acid sequestrants on a long-term basis, we actually need to use a combination of the two. Now, this is the use in bile acid sequestrants. We've also been down this approach in other areas. Recently, we've had a novel formulation of niacin, and the clinical development of that, which involved the development of a flush inhibitor. Now, it was all very well to develop a flush inhibitor in rats that worked very successfully in those animals, but how did you validate it in man? The objective method of doing it was very simple. You actually imaged people with a thermal camera, and you looked to see how red their faces went. Now, that's very good if you're actually in a controlled temperature environment, and you have about 5 people there, and you can have $100,000 of kit. You cannot do that if you're doing a 5,000 patient validation study. So again, Harold Bays was involved in that case in actually putting together something called the Global Flush Sensitivity Score, or the GFSS score, which he validated against thermal imaging and was actually used as one of the key things in developing the niacin loroperam formulation that is now actually available in worldwide, certainly in Europe, and will be worldwide very in the near future. This just gives us a nice flavour of what we should be doing with these scores. There are other areas where we haven't done it. There is huge controversy about statins, for instance. Everybody knows that statins are great drugs. We're prescribing them to very large numbers of people. But everybody argues about how much myalgia do they cause, how many headaches do they cause, how much sleep disturbance do they cause. We have very, very little objective evidence. One of the things I think that will be a challenge for everybody, particularly now that we're looking in health economics terms, that compliance and adherence critically determine the health economics of any of these long-term therapies, is that we're going to have to systematically look not just at new agents for actually side effect scores and what effects they have on quality of life as measured by EQ5D and other such statistical scoring models. We're going to have to do it not only for new drugs, but for old drugs. And only when we have this as systematically established for the older agents as we do for the new, are we actually going to have a way of doing health economics sensibly and determining whether this is the way to go for actually determining long-term acceptability of drugs into the National Health Service or any other health service in the world.